Then when we get to some of the pathology biomarkers that you mentioned, similarly, it's been, probably about a decade that we've had pathology tools that could basically accomplish things that a pathologist could do and just do so maybe a little bit more quickly, maybe in a little bit more of a standardized fashion. And what we're really seeing in the last few years are moving to AI predicting things that a pathologist wouldn't be able to do from a standard H&E slide. So with these tools that you mentioned, like quantifying immunohistochemistry, in general, that's kind of a routine workflow. And actually, at our hospital, we don't employ these AI tools to quantify the immunohistochemistry. Although I know we get referral cases where I'm pretty sure that AI had helped because we get estimates of things like estrogen receptor percentage as like 73%. And pathologists are, most pathologists don't quantify things that precisely. So I know these tools are in use and are sort of being employed in that fashion. Uh, they do have the potential, even when these tools are just doing what a pathologist is doing, but more systematically or in a more reproducible way, they do still have a potential to provide some advantages to patient care. We saw some data presented at ASCO of a study where they had 100 pathologists reviewing HER2 immunohistochemistry. And pathologists are pretty good at distinguishing HER2 2 plus versus 3 plus, which is the cutoff for HER2 positive breast cancer from immunohistochemistry slides. And that's what actually the antibody concentration was designed to do. It was designed to be at the range to detect that level of HER2 expression. But with these antibody drug conjugates that work for HER2 low and HER2 ultra low disease, we're now at the lower end of detection of HER2, much lower than the sort of antibody concentration was optimized for. And so there's a lot of discrepancy when pathologists are reading those cases at the low end of the spectrum. But in this study presented at ASCO, they had 100 pathologists read about 20 HER2 immunohistochemistry cases with or without a commercially available AI tool. And they saw much better concordance in that HER2 ultra low and HER2 truly zero category, suggesting that we might be able to more effectively or at least more consistently select patients for some of these antibody drug conjugates directed towards HER2 that we have available today. So they can still have some improvements even when they're just sort of doing exactly what a pathologist would do. And those are perhaps pretty close to being having the potential to be used clinically. Um, Especially if you have maybe pathologists that are not, breast specific pathologists, those who are not looking at the breast biomarkers on a day-to-day basis. I think that has a lot of value to potentially improve consistency of care across the map in the United States as well as globally. But I think what's really exciting is in pathology space, and what we're seeing a lot of at San Antonio this year, are these biomarkers that are identifying things that we wouldn't previously be able to identify. In particular, we've seen a number of studies that are predicting risk of recurrence for early stage breast cancer, either through predicting the genomic test that we use, like Oncotype DX or MammaPrint, or by directly predicting the risk of recurrence. And some of these studies have shown better accuracy at predicting that recurrence risk than our existing genomic risk tools. And so I don't think we're there today, but I think in the near future, we'll be using AI pathology-based tools to better risk stratify patients, to be able to improve our selection of patients for treatments like chemotherapy and cell cycle inhibitors. Um, and I think that there'll be continued emerging use cases in pathology as time goes on and as these models improve.